Welcome to Endocrine Grand Rounds for today. We are very pleased to have Dr. Sham Kakar from the Department of Physiology, who also has joint appointment with us in the Division of Endocrinology in the Department of Medicine and also in the Department of Biochemistry and Molecular Genetics. He obtained his initial training in India from NDRI. The National Dairy Research Institute, where he did biochemistry, post-graduation and Ph.D., and subsequently had been at the University of Alabama in Birmingham for about 13 years or so, before he came to Louisville in 2000 and 2000, I think. So he has been on the faculty here. Now he's a professor. Dr. Kakar has been very active in the field of research, having been funded by the NIH. Has been PI, co-PI, and mentor, and multiple grants, many of them currently active. He has over 113 peer-reviewed articles and more reviews and abstracts that have been presented at various meetings. We have had the pleasure of listening to him speak on different topics. One of the things that he had identified was PTTG, which very much related to endocrinology. And today he's going to talk about a very interesting topic, which is therapeutic approach to target cancer-mediated cardiac cachexia. Dr. Kakar.
Thank you very much for a wonderful introduction. We know Prakash from the very first day I landed here was a resident at that time. That's it. He was that. So yeah, Dr. Steve Winter, who was director of endocrinology and metabolism, he and me knew each other before I came here. Even we never met before. I may have met, but I don't remember. So he said, why don't you become part of endocrinology? Because I was working in endocrinology. I grown a GnRH receptor, angiotensin II receptor in early 90s, which was a very hard job. Then shifted to cancer research related to ovarian cancer, which is endocrine-related cancer. So for the last few years, what I've been doing is merging cancer and cardiovascular system, because I had a 4-year training in cardiovascular system when I was in Medical College of Ohio. So what I'm going to talk today is the cachexia and how we can target it. This is something which I never learned till 5 years before. So I hired a postdoc, Alex Strogan, and he has Ph.D. in muscle power from the University of Louisville. So in our first meeting, he said that the compound you're using as an anti-cancer drug, let's try it to reverse the cachexia too. Since he was a muscle biologist, so he started that, let's check on the muscle cachexia. What is cachexia basically? Cachexia in simple terms is a loss of skeletal muscle mass as well as loss of strength. And cachexia can be a result of several things such as septic or sepsis before you move forward. Maybe. No. Okay. So sepsis, infection, viral infection, and chronic kidney disease, all these factors really affect the muscle and induce the muscle weakness and the loss of muscle. And cancer is also a big factor for inducing cachexia. And it results in 40 to 80% of the patient with cancer, depending on the oncological state. Late stage induce more cardiac cachexia than the early stage of cancer. And as I said, cachexia is associated with weakness of muscle and loss of muscle mass. So it has been reported that skeletal muscle are the major organs which are affected by cancer as a result of cachexia. But there are other tissues which have not been studied extensively, include liver, heart, adipose tissue, and brain. Even though it causes 30% of the death directly by cachexia, but not much attention has been paid to it because if cancer patient die, everybody thinks it's because of cancer. Whereas it may not be direct result of cancer, but the side effect of cancer, which we call cachexia. So it may be because of death of cachexia, and I will present you the data that cancer definitely causes muscle cachexia. And the more interesting, what we found out that it also causes cardiac cachexia. So the patient who are with cancer, they are more prone to get heart failure and end up in death or heart failure. So with that background, I start working in this area because it seems to be interesting to me and emerging two field. The model we use is a mouse model, which other people have used, using C26, which is a colon cancer cell line. What they observed that this cell line is very aggressive and induce cachexia, and male are more responsible to result in cachexia than the female. Since I'm working in ovarian cancer, so I thought let me test if we can induce cachexia by ovarian cancer. For that purpose, we use NSG mice, which are immunocompetent, immunodeficient mice, and implanted the ovarian cancer cell line intraperitoneally. So they develop large tumor, very aggressive tumor, and they metastasize to the ovaries. So the compound we are using for last several years is Vidoflurin A. Vidoflurin A is a sterol lactone, and it is purified from ashwagandha, also known as winter cherry. It's known for its anti-inflammatory property and inhibits the cell proliferation, tumor growth in nude mice, and also target cancer stem cell. So we have published a lot of paper on this compound. So Alex told me when we have meeting, he said, let's try your compound if it affects the cachexia also. So we generate, and Vidoflurin is really known for a lot of its good effect, like anti-inflammatory, anti-proliferative agent, apoptotic agent, cancer stem cell. It targets cancer stem cell. Also, it inhibits the cell migration and invasion. Also, it serves as an anti-cancer compound. So there are several papers on this compound, but none of the papers so far before we started have shown its effect on the text. So that was interesting. And with that, we designed the experiment. We got NSG mice. And after 1 week, the first sign you see the initiation of cachexia is the loss of muscle strength. So we got the animal injected with the tumors zero. We measured the grip strength. Then after 1 week, we injected the tumor cell and did the body weight and grip strength every week. And after 1 week of implantation of tumor cell, we start treating with WFA. Initially, we used 2 doses, 2 milligram and 4 milligram per kg based on our previous result. So this experiment was carried out total of 4 weeks. And before we sacrifice the animal, we did a cardiac cachexia as well as muscle cachexia and many other mechanisms in the tissue. So the way to measure cachexia, muscle cachexia, is a grip strength. So what you do, you have this animal grip centimeter, and there's a bar here. You allow the animal to catch this bar with the foreleg to front paws and pull them till they release this bar. The strength required is called grip strength, which is measured by the meter. For total grip strength, you have a grid where you allow the animal to hold this grid This is much stronger than just the bar, and try to pull the animal till they release the grip. So that strength is measured as a total grip strength. So before implantation of cell, we measure grip strength for all the animal, and there was not any significant difference from one animal to another. So these are divided in two groups. One group we injected just a vehicle, other group we injected with the tumor cell. So just after 1 week of injection of tumor cell, ovarian cancer cell, what we found out that there was a significant loss of grip strength just after 1 week, which is shown here. This is the foreleg, and this is the total grip strength pause. So, and we continue measuring. Then after 1 week, we start injecting vidoflurin A in the animal, in control animal, as well as in tumor bearing animal. So if you see here in control animal, when we treat it with WFA, either dose of WFA increase the grip strength, which is known function of vidoflurin A, that it builds the muscle mass. So that's why we see require higher force than control animal. And the grip strength, as I said, was significantly reduced, but it was almost attenuated with either dose of vidoflurin. And this is the foreleg, this is the total grip strength. And we continued till 3 weeks after treatment with vidoflurin A, and every week we saw similar results. And this is the end of the trial, or 4 weeks. So we still have weakness in the grip strength, which was highly significant. And when we looked the body weight, there was a loss of body weight, which is also known as a function of cachexia, that and you have seen cancer patient, they have become very weak. They have a hard time to walk, hard time to eat, and they cannot do much work as they could do without cancer. So cancer causes the body weight loss as well as the adipose tissue loss. I'm not showing adipose tissue here or the fat, but that also is a function of cachexia. So body weight was significantly reduced, which was measured after sacrificing the animal. Tumor, of course, we found by injecting these cells, which is not new information, but we have seen in other trial, it was really large tumor, peritoneal tumor. And when we treated with WFE, either dose significantly suppressed the tumor growth. Ovaries were the first organ where intraperitoneal tumor spread, metastasized to the ovary. That's why we could see increase in ovaries mass, and then it was to some extent reduced, but never came back to the normal weight. So since the forelimb as well as all weakness was there, so we wanted to see if there was a loss of muscle mass. So we did the cross-sectional area measurement. So you stain the tissue, these are the muscle tissue, and we stain with the H&E staining. And what you see here is the cross-sectional area of the muscle cell in normal animal, and WFA, as we saw, has some positive result. The cross-sectional area was increased to some extent. Where the animal was bearing tumor, the cross-sectional area was reduced, which reflects the loss of muscle mass. And when we treated with WFA, the cross-sectional area was regained. So that shows that definitely there's a loss of muscle mass as well as muscle strength. And we further went and quantitated the cross-sectional area, and we can see there was a significant decrease in cross-sectional area of the tibial muscle, and this was attenuated to a great extent by treatment with WFA. So this is the diameter of the cross muscle cell, which was also reduced, and that confirmed that the cachexia has developed, especially in muscle, and we'll see in cardiac tissue also. So we study a lot of the signaling pathway, which are activated by tumor leading to the cachexia. And one of the pathway or the new molecule which are in the literature are inflammasome. And there are several type of NLRP, and NLRP3 inflammasome are more common. So there are three genes in NLRP3, ASC, and caspase-1. When they're activated by PAM or DAMP, which are coming from the tumor and other cytokine, there is an increase in expression of ASC, caspase-1, and NLRP3. And intracellularly, they form a inflammasome, which can induce their function. So when capsase bind to ASC as well as NLRP, it gains its activity. Pro-caspase get converted to caspase, active caspase. Active caspase convert pro-IL-1 beta, which is a strong inflammatory cytokine, to active IL-1 beta and also IL-18. IL-18 forms a pore in the membrane and allows the cytokine to spread out of the cell, which goes to other cell and induce their function. So if we put things together, this is what we concluded from our experiment. The tumor induced TNF-alpha or other cytokine, and they activate this NF-kappa B pathway, which is a pro-inflammatory pathway, and induce the secretion and synthesis of several inflammatory cytokines. And this is the inflammasome, and they affect the skeletal muscle, cause atrophy of the skeletal muscle, which results in loss of muscle mass as well as weakening of the grip strength. No, we wanted to see. So I hired another postdoc. She had experience in cardiovascular system, and she was Ph.D. from the University of Louisville from Physiology. So she said that let's look at the cardiac muscle, because if it's affecting the skeletal muscle, it may be affecting the cardiac muscle also. But muscle has similar structure. So we look the echocardiography, and we look the heart size. In this case, you can see the control have a regular size, whereas the tumor-bearing animal have smaller heart. It was because of the hypertrophy of the heart, which is one of the function of cachexia, that it will reduce the heart weight and the size. So with treatment with WFA, they gain back the size as well as the mass, which I'm quantitating here. So if you look the heart here, this is the normal heart weight, which is normalized to tibial length, because the tibial length is not affected by any drug or any other factor. So when we normalize, we saw a significant loss in the heart weight, and which was gained almost to normal level by WFA, either dose. So this is the left ventricular diameter, which was also reduced, and also cross-sectional area we have seen reduced. That's showing atrophy of the cardiac muscle, and that's why the heart went down and the weight also went down. What happened here? So if we look at cardiography here, well, it looks like some transformation is there. I'm not able to show beating of the heart, but we calculated the fraction shortening, ejection fraction, diameter of the heart. All these calculations are done. Initially, you have echocardiograph, which measure all the function or all the diameter and other function of the heart, and then you use different formula to analyze the function. So if we look here, the heart rate also was reduced significantly, where WFA recovered it, and the fraction shortening was significantly reduced. These are the definition for each one: fraction shortening, ejection fraction, cardiac output was reduced also, and LV mass also was reduced. These are the systolic function of the heart, but diastolic function, if you look here, diastolic function was reduced, but they were not recovered fully by treatment with WFA, which could be the secondary function of WFA to target diastolic function. Another reason could be we treated the animal 3 weeks. It could be that they require longer treatment, which we have not done yet. So that could be the reason. IVRT is also diastolic function, and there is the time iso isovolumetric relaxation time, which was increased, but it was not decreased significantly on treatment with WFA. So what we can see from these results that systolic function is fully recovered or almost 90% recovered, where diastolic function is partially recovered, but not fully recovered with the WFA. So here, so what we, something is wrong with the transformation of the slides, but what we could see here, this is the normal, and it was beating normally, but in this case, if you look this heart, which is a tumor bearing heart, you will see the missing of the heartbeat here. You see here. So 2-3 peaks are missing here, or beats are missing, which is a arrhythmia of the heart. And many cancer patients may die from an arrhythmia of the heart because of the cancer, but nobody pays attention to it because they say that is because of cancer they die. Nobody really pays attention for diagnosing. WFA treatment recovered it. There was no missing beats, and arrhythmia was not observed in all the animals we have. So this is the diastolic function, EP, and the blood flow. They were also affected. And if we look here, the analysis, this is the EP, which is the diastolic function, AP. And here, this is the tumor-free animal control, WFA treated. As we saw some gain of muscle mass by WFA treatment, so the ratio was increased to some extent, but in this case, this ratio was completely changed. Peak A was reduced, the peak A was increased, which is the abnormality of the diastolic function of the heart. In quantitation, if you look here, this was the E over A ratio, which was significantly reduced, but it was not fully recovered by WFA treatment. Same thing over here, E over E dash ratio, which was also significantly reduced. So from these experiments, it's very clear that when we induce a cancer in animal, it is not only affecting the skeletal muscle, but also affecting cardiac muscle also, or the cardiac function. So this is a cross-sectional area of the cardiac muscle. And if you look here, normal weight, which I already have seen, the myocyte cross-sectional area was significantly reduced and almost recovered by WFA. This is the troponin I, which is secreted in the blood, and we saw very low level in circulation in tumor-bearing animal. MHC alpha and MHC beta, these are the myosin heavy chain alpha and MHC beta. The MHC is a chart in adult form, whereas you see MHC beta in fetal. So in cancer, what we saw, reverse of thing. So MHC alpha went down. That means the adult myocyte behave like a fetal myocyte, where MHC beta, which is a reverse of MHC alpha, went up. That means the fetal behavior of the muscle increased, and WFA attenuated both conversion of alpha to beta. The other function which we see is abnormality in the heart is building of the fibrosis, which also affect the cardiac output as well as normal function of the heart. So these are the heart muscle. We stain with myosin, Mason trichome staining. So we stain the collagen, and we didn't see any kind of a collagen deposit or insignificant fibrosis. This is the index of the fibrosis, whereas the tumor-bearing animals showed highly significant buildup of the fibrosis. And these fibrosis were eliminated by treatment with WFA. Quantitation is shown here, significant increase in fibrosis or fibrotic area, and then it was reduced to a grade level by WFA treatment. The other factor which are secreted from the tumor are angiotensin 2, but we saw angiotensin 2 was elevated in the tumor-bearing animal, and we know angiotensin increase in angiotensin 2, which could be activation of RAS, renin angiotensin 2 system, causing the heart problem. This is one of the major factor in human. Anytime RAS is activated, the angiotensin 2 in the circulation goes up, which cause hypertension and abnormality in the heart. So angiotensin in circulation went up, and WFA was reduced, not fully, but to some extent. This is the precursor of angiotensin 2, angiotensinogen. As you all know, angiotensin 2 come from the angiotensinogen by conversion of angiotensinogen to angiotensin 2. And then these are receptor in rodent. When I clone angiotensin 2, what we found out that there are two isoform of angiotensin 2 receptor. So we label one as the AT1A, another one AT1B, and AT1. And there's another receptor which is angiotensin 2 receptor. This is angiotensin type 1. This is type 2. Type 1 is a contraction. It mediate heart contraction, whereas this is the vasodilator. The receptor type 2 is a vasodilator. And then we look at several inflammatory cytokine, GN-alpha, IL-6, MIP, which is a homologue of IL-8 in human, interferon gamma. The expression of all these were upregulated. At the same time, we saw increase in level of these inflammatory cytokine in the circulation, and which are detrimental to any organ in the body, and they were attenuated the treatment with WFA. The other factor which are common in circulation in cancer patient, increase in ATP, and treatment with the WFA reduce the level of ATP, and ATP works through two receptor, P2X7 and P2X4. The expression of both the receptor was elevated, and we also did NLRP3 inflammasome, caspase-1, IL-beta expression of this gene was increased. Same thing, IL-118 and HMOX is the anti-inflammatory molecule, is an enzyme, and its expression was reduced. So you can see that it's not only inflammatory cytokine were increased in tumor-bearing animal, but there was a reduction of HMOX1. So same way we did a lot of signaling pathway and came to the conclusion, which is shown here. It's very hard for me to go each one because it takes me a long time to explain. But in summary, I can say there are a lot of factors which are secreted from the tumor, including angiotensin 2. Angiotensin 2 has basically two type of receptor, AT1, AT1-2, and then there is another receptor which induce inflammatory is TL4. So this is the TL4 pathways which is activated in tumor, and it activates the NF-kappa B pathway, which is one of the major pathways, and induce the secretion of inflammatory cytokine. So this is the inflammasome. So the net result is atrophy of the cardiac muscle. That's what we found out. And vidofludimus inhibited the production of this cytokine, at the same time the inflammasome production. So as a result, they vidofludimus reverted the impact of cancer. So in conclusion, generation of peritoneal ovarian tumor in mice results in development of muscle and cardiac cachexia. Treatment of animal with WFA restored the cardiac cachexia as well as muscle cachexia. WFA reduced the cytokine and inflammasome generated by tumor. Left ventricle cachexia was attenuated by WFA. Systolic function was completely preserved, but diastolic function was partially preserved. And we could observe arrhythmia in all the animals, human-bearing animal, and which was reverted or reversed by with a treatment. Now, very nice data. We could see that the inflammasome are inflammatory cytokine and the heart effects are there. So we submitted a graph. And reviewers are always critical. But they came up that this WFP is the anti-cancer drug and it's used to, it can inhibit cell proliferation at the same time tumor growth in vivo. So they say what you're showing, the reduction in reversal of cardiac or muscle cachexia is because of the reduction in tumor burden, which is thus reduction in inflammatory cytokine, inflammasome, and other pathway study. So I went to nap for 30 minutes, which always I do when I have to think. I said what we can do, how we can answer the question of the review. So we came up with the pharmacological model. And we know angiotensin 2 causes the cardiac disorder, which mimics cardiac effects. So with that thought, we went for the pharmacological model by infusing angiotensin 2 into animals in a continuous manner. So what we did, we took these C57, which are immunocompetent mice, and we implanted the angiotensin 2 or saline pump into the skin, so upper part of the skin, and the angiotensin 2 pump, these are osmotic pump, they release angiotensin 2 in a continuous manner, and you can buy different capacity of the pump, and the pump can be releasing angiotensin 2 in a continuous manner for 28 days. This pump was meant for 28 days. There are pumps which can go longer, but we did experiment for 4 weeks. That's why we use the 28 days osmotic pump. So what plan is that after 1 week of implantation of the pump, it could be saline as a control or containing angiotensin 2, and then start taking the WFA. In this case, we use 1 dose, 4 milligram, because we didn't see a significant difference between 2 milligram or 4 milligram. So instead of having 2 doses, we just went for 1 dose. So as angiotensin 2 is also known to cause muscle cachexia. And again, we did the grip strength on weekly basis. And just after 1 week of implantation of angiotensin 2 pump, we could see loss of grip strength for limb as well as the total grip strength. And this was weekly performed, and we could see weakness all over the experiment, all 4 weeks. So same thing with the muscle mass was reduced significantly, and with treatment with WFA, it was normalized. And WFA again by itself showed increase in muscle mass. So this is tibial, gastrocnemium, and this is the quadricep muscle. There are 3 muscles at the lower part of the leg. So if you take them and weigh them, they show this kind of loss of weight. So at the end of the experiment, we took the heart out, but we see the reverse of hypertrophy. The cancer caused hypertrophy, where angiotensin caused hypertrophy, increase in the mass of the heart. So we could see an increase here, and by weighing all the heart and then normalizing to the tibial line, we could see a significant increase in the mass of the heart, and it was attenuated by WFA treatment. ANP, BNP, and MHC alpha. ANP stands for anterior natriuretic peptide. BNP is bone natriuretic peptide. MHC is a myosin heavy chain. So there was a significant increase for ANP, BNP, and MHC alpha. These are the markers for hypertrophy of the heart as well as fibrosis of the heart. So we could see increase in this one, and WFA decrease their level. So fibrosis, again, we look for the fibrosis in the heart. And here we are using Mason trichome staining. So you could see some deposition of collagen, which is the result of fibrosis, whereas treatment WFA in regular animal or control animal reduced to, then it was significantly increased in human-bearing animal and WFA. These are the perivascular, and it also causes the fibrosis with the perivascular as well as the muscle cell. So we were trying to get some photograph yesterday from muscle as well as using different staining, WGA, which is more specific to the fibrosis. Somehow we could not take picture what we could see in the microscope. So we had to go to another confocal microscope to take the picture. So anyway, but this fibrosis was significantly increased in a tumor-bearing animal, and treatment WFA reduced our fibrosis. So these are other function of the heart, like this is the long axis left ventricle posterior wall thickness, which was increased significant. This is the fraction shortening of the left ventricle, which was significantly reduced. And this is the left ventricle's short diameter was reduced. Same thing, velocity was decreased, left ventricle velocity. This diameter was increased. This is another way of measuring the diameter. It was also increased. So basically, it's a sign of a marker for hypertrophy. The diameter of the heart or the wall thickness was increased. And now we did some here. I don't know if it will work or not. It looks like it's not going to work. What if you come and I can show you? So this is the normal heart where we see very nice contraction and complete nothing not abnormal. And WFA did not cause any abnormality, whereas the animal heart, which was analyzed, what we saw, the video could show that there is a abnormal contraction, and then once it started beating, it stopped the contraction. It started vibrating. Contraction was lost. The heart you could see is just vibrating, which is really abnormality of the heart. Then WFA treatment to recover to a great extent, which was a very interesting observation. Oh, no, it starts here. And WFA didn't effect in control animal. You see here, see, it's not contracting normally, then it's shifting, vibrating. So which is abnormality, and then this WFA treatment attenuated this abnormality. So one of the interesting thing, everybody studying left ventricle abnormality. Nobody pays attention to right ventricle. There have been several reasons. I have talked to several cardiologists. First, the structure of right ventricle is very complicated. Secondly, right ventricle pumps blood to the lung. It's only one organ, where the left ventricle pumps blood to the whole body. So anytime they find abnormality in the heart, they believe that it's because of the abnormality of the left ventricle. Whereas the right ventricle abnormality is even more causing the heart problem than the left ventricle. So this I have shown that abnormality is not observed on the left ventricle, but we observe abnormality in the right ventricle also. And treatment with WFA reverses. We have a number of drugs for left ventricle, like losartan, beta blocker, and so on. But there's no drug for the right ventricle. So that's why we are working on this aspect, shifting our strength towards the right ventricle, where we can see if WFA stand up, it can be used with. So inflammatory cytokine, as expected, they went up, and then they were attenuated by WFA treatment. And these are the same inflammasome. MHC alpha didn't change, but MHC beta was upregulated. So what we conclude from this part of study that the inflammasome related ASC, capsase, and NLRP3 expression went down, and which forms the inflammasome, and caspase inactive gets converted to active caspase 1, and active caspase 1 convert pro IL-1 beta to active IL-1 beta, and number of inflammatory cytokines are regulated by infusion of angiotensin 2, which increase the concentration of angiotensin 2 in the circulation and affects the heart. So that forms a heart remodeling and induce number of abnormality in the heart. So in conclusion, we can say angiotensin infusion results in the development of muscle trophy and cardiac hypertrophy and cardiac dysfunction that may be cachexia. WFA treatment attenuate loss of muscle mass and reverse cardiac dysfunction. WFA reduces the level of pro-inflammatory cytokine induced by angiotensin 2, and WFA reduces the level of inflammation induced by angiotensin 2. Reversal of cardiac function is independent of cancer burden in this case. So therefore, we can say the effect of WFA is direct on the cardiac muscle instead of stress human, because there's no scale. So with that, so I've been working on a combination therapy for cancer drug, and since WFA is showing highly positive result for the cardiac function, so we designed a clinical trial. So doxil or doxorubicin, doxil is a liposomal preparation of doxorubicin, and it's less toxic than doxorubicin. Doxorubicin itself causes myocardial toxicity, and we know the cancer causes myocardial toxicity too. So we plan a clinical trial, and it's phase 1 and phase 2, where we are using vidofludimus with doxil in human. And both phase 1, we will have 18 patients. Phase 2, we will recruit 54 patients. So outcome will be looking for the toxicity profile, overall survival, patient response, progression-free survival, stable disease, and cardiac function, quality of life in patient. We improve their health, they will have better quality of life. This has been approved by FDA, and the doxil is a standard of care. It's used as a second-line chemotherapy for treatment of ovarian cancer. And WFA is a purified compound from ashwagandha, and which is injectable. Therefore, we try to avoid second injection of doxil. Doxil is also injectable, intravenously provided. So in this case, we'll be using all of preparation of ashwagandha, which is a high source for vidofludimus. But in this case, it's not regular ashwagandha you can buy from market as a supplement, but this is especially formulated after working for a couple of months and doing different preparation. This gives high content of vidofludimus. So it will provide a high level, but it will be taken orally every day. We have dose. We are going to have 3 doses in phase 1, and then find out which dose is tolerable and effective. Then go to phase 2 with the dose defined from phase 1. So we are recruiting the patient. So if you are the clinician, so if you have some patient who are suffering from ovarian cancer, recommend to Dr. Goldsberry. She is the OBGYN department, and she is the multi-PI on this trial. Dr. Miller, Redman, Dr. Hahn, they are the advisor. Dr. Hahn will be doing cardiac function. So with that, I'd like to acknowledge several people. Alex Stragan was postdoc with me under T32 training program, who initiated this project. Nadia Khan, she was cardiovascular trained postdoctoral fellow, worked with me. Partha Roy, Rama Shah, these are the people from India, from IIT, and we had one review together. Zepeng Hong is the MD PhD. He's a cardiologist, a national cardiologist. He's a right ventricle specialist. Then K. Liu is MD PhD also. He looks the heart structure, fibrosis, and all of those things. Whitney Goldsberry, she is a part of the clinical trial. From clinical side, she will be PI. Don Miller, of course, is my friend, my boss. I moved with him in 2000. He was at University of Alabama, and he made me to move here. The funding came from NIH. Then we talked to the ovarian cancer awareness of Cachexia about this trial. They were very excited, and they gave us the funding for phase 1 trial. Then the Brown Cancer Center gave us heavy discount for the trial, and we are having R1, which is provisions, and will be the end of this month. So if it's funded, we'll have enough money for any clinical trial. These are students who have worked with me in summer or during their master student, and these people are part of the clinical trial. So I appreciate their help in moving forward. And with that, I will stop here. We'll be very happy to answer any question or concern.
It has no effect on appetite or any other things. Are they all maintained on it? Are there any other change? No, the WFA.
Yeah, when we injected into normal animal, control animal, same dose, we didn't see any side effect up to this dose. The higher dose, if you use 6 milligrams per kg, definitely the animal gets sick. So it's toxic dose. Whereas up to 4 milligrams is safe. So that's why in phase 1 we'll test 3 doses. First dose is toxic, we'll go back lower. First is tolerable, then we start with 2 grams per day, then we go to 4 grams. Form of cancer.
So is the effect of the tumors on the heart, is that dependent on the tumor size or not?
Yes.
It is.
Yeah. So as I said, it varies from 42% to 80%. Patient develop cachexia. It is more common in advanced cancer. They have large tumor or metastatic.
If there are any questions, then.
Where you check it. Slowly get out. Yeah. So, now that we close those. What's this? Yeah, the question is what ashwagandha is and what is made of. Ashwagandha is a plant product. From ashwagandha is a extract of ashwagandha, mainly from the roots, and it has 300 member of the withanolide family, and withaferin A is a major component and is well studied and well published. The other components are there, withanolide A, withanolide B, and many other, but they have not been well studied. But studied.
Okay.
Oh, lost again. Okay, the second question is angiotensin 2 inhibitors such as temsirolimus might also be useful to treat cachexia. I've not read about it, but it's possible. The right ventricle, there is no drug. There's no drug for cachexia itself, but definitely there are drugs like angiotensin 2 inhibitor, like ACE inhibitor and losartan, which blocks the angiotensin 2 receptor. They do not target cachexia. They are good for recovering the left ventricle, but they have not been shown to reverse cachexia. This is Withenia somniferia is the one plant extract. The plant name is Withenia somniferia, where we get vidofludimus as a purified compound. Okay, any other question?
So, but the cancer cachexia has nothing to do with angiotensin.
No, angiotensin 2 induced cachexia, muscle cachexia also, which is already known as part. But there is no treatment.
Dr. Kakar, do you have IP protection for your formulation?
Yes, we have applied. So once we get some results from the patient, that will make the patent very valuable. So we are protecting it as a formulation, but we have talked to OTT and filed the patent.
But ashwagandha you cannot patent, right?
You cannot patent it because this is especially formulated to provide high content of vidofludimus. That's why we can. But we are waiting some patient data which will make the filing very strong.
How about your animal data?
Animal data, yes, we have shown, but OTT told that you cannot patent vidofludimus as such because it's a natural product and natural products are very hard to patent.
Yeah.
But if the new formulation works, then it's patent.
I see. Okay, thank you very much for sharing your great data.
Thank you.